We go to the next question.
Yes, sir.
Go to the next question.
Sir, myself presenting, sir. Calcium and anesthetics, sir. Good evening, sir. Introduction. Calcium has many essential biological functions. Total body content is 1,399%. In intracellular, 1%. In extracellular, 0.1%. Total plasma calcium level is 2.5 millimole per liter. 9 to 9 per deciliter. Total calcium, protein bound is 40%, that is albumin. In 60%, it is ultra filtrable. In 60%, it is 10% complex to anions, and 50% is attached with ionized calcium. This functions of calcium are in excitation, activation of the clotting enzymes in the plasma. It preserving the bone density. It helps in the release of neurotransmitters. It is a major intracellular second messenger, maintaining all cells and connective tissues in the body. It is essential component in the production of enzymes, hormones that regulate digestion, energy, and fat metabolism. Calcium homeostasis. The three organ systems are intestine, bone, and kidney. Three hormones are parathermone, vitamin D, and calcitonin. When plasma calcium is decreased, this parathermone secretion increased. Parathermone secretion is increased, and vitamin D also. It directly acts on the bone and kidney. In bone resorption, in kidney, it decreases phosphate reabsorption in the proximal converter tubules. Increase calcium reabsorption in the distal converter tubules. It indirectly acts on the intestine to increase calcium absorption via vitamin D. This all creates the increased plasma calcium towards the normal. Calcitonin. It is 32 amino acid. It is secreted by the parafollicular cells of the thyroid gland. Directly inhibition of osteoclast. So it promotes calcification by increasing the activity of osteoclast. So it decreases the bone excretion in the urine. When plasma calcium is increased, calcitonin will act and it will decrease the plasma calcium towards the normal. Pharmacology effects, calcium handling in the nephron, 67% of the filtered load is reabsorbed in the proximal converter tubules. Loop diuretics and diuretics. Our anesthesia relevance are effect of calcium on the myocardium, vascular smooth muscles, and the blood coagulation. Coming to hypocalcemia. Hypocalcemia is defined as plasma calcium concentration of less than 2.1 millimole per liter, or the ionized calcium level is less than 1.1 millimole per liter. Etiology. Most frequent cause in critically ill patient is hypoalbuminemia and hyperventilation. Medical causes are acute renal failure, CKD, vitamin D deficiency, and magnesium deficiency. Surgical causes are post-parathyroidectomy, thyroidectomy, and cardiopulmonary bypass. In iatrogenic, by excessive citrate red blood cell transfusion during liver transplantation and hypersurgeries. Signs and symptoms: central nervous system, mental status changes. Vasospasm and bronchoscopy. Signs are positive Stroke sign, contract of the facial muscle produced by tapping the ipsilateral facial nerve. Trouser sign, blood pressure cuff is inflated to 20 mm of mercury above the baseline level of systemic blood pressure. Arterial blood flow to the hand is occluded for 3 to 5 minutes. So it can produce corbopedal spasm, that is flexion at the wrist, flexion at the metacarpophalangeal joint, and extension at the interphalangeal joint. Treatment: intravenous calcium salt solutions available in 10 ml of 10% calcium chloride and 10% calcium gluconate. This calcium gluconate is usually preferred because it has lower osmolality, irritating when giving IV. Calcium chloride has 3 times more elemental iron than mole elemental calcium than calcium gluconate. Elemental calcium is 27 mg and 9 mg. Sir. Dosing regimen: bolus dose of 100 mg of elemental calcium should be given over 5 to 10 minutes, and it should be followed by continuous infusion at the rate of 1 to 2 mg per kg per hour, or at least for 6 hours. In between, we have to check the ionized calcium levels in the blood. Maintenance of oral calcium therapy. The daily maintenance doses 2 to 4 months in adults. Orally available tablets are calcium carbonate and calcium gluconate. When calcium alone is not sufficient for control of hypocalcemia, we should give along vitamin D also. Definitive treatment is recognition and correction of the underlying disorder. Management of anesthesia in hypocalcemia patients. Symptomatic hypocalcemia must be treated prior to surgery. Intraoperatively, it may occur with any hyperventilation or administration of bicarbonate levels. Sudden decrease in serum calcium may be seen in early postoperative period after post-thyroidectomy or post-parathyroidectomy may cause laryngosspasm. Hypercalcemia, the mnemonics are painful bones, renal stones, and abdominal groans, and increased calcium reabsorption from the GAT. The syndromes are milk alkaline syndrome, vitamin D intoxication, any granulomatous disease like sarcoidosis. So it decreased renal excretion in the renal insufficiency patients. Most common causes are primary and secondary hyperparathyroidism. Second most common is malignancy, hyperthyroidism. Clinical features, CNS like confusion, decreased state of consciousness, psychosis, and irritability. In CVS, hypovolemia, hypotension, and shorter QT interval in the ECG changes. GAT, nausea, vomiting, dehydration, constipation, and pancreatitis. In renal system, polyuria, polydipsia, nephrocalcinosis, and urolithiasis. In produce thrombosis. Treatment is indicated when hypercalcemic crisis or any cancer related. Hypercalcemic crisis means hypercalcemia is associated with any adverse effects or any severe symptoms or any serum calcium more than 14 milligram per deciliter or ionized calcium is more than 3.5 millimole per liter. Hypercalcemia usually presented with hypercalciuria, which produces osmotic diuresis. It leads to hypovolemic shock. So we have to infusion isotonic saline at the rate of 200 to 500 ml per hour, and it produces natriuresis. So it promotes renal calcium excretion. Our goal is to urine output is 100 to 150 ml per hour. Includes diuretics furosemide, 40 to 80 mg IV every 2 hours. It indicates only volume overload as it promotes hypovolemia. Glucocorticoids, prednisolone and hydrocortisone daily for 3 to 5 days. Prednisolone doses for 40 IV, 100 to 400 mg IV or oral. For first aid agent in severe hypercalcemia, it potent inhibitor of phosphoric drug zoledronate and pomegranate. Dose 8 ml is 90 mg IV. Both drugs mostly asymptomatic, so medical treatment. Sir?
Your audio is breaking now and then. I think it's better without the video. You can switch off the video and use only
Yes,
your
sir.
microphone.
Yes, sir.
Okay, your audio getting distorted with your video on. So you can switch
Yes.
off the video part and
Yes, sir.
we'll continue with the audio.
Yes, sir. In moderate deciliter, if it is asymptomatic, wait and watch. If it is symptomatic, add fluids and bisphosphonates. If it is severe, we have to give drugs. If it is resistant or recurrent hypercalcemia, we can go for hemodialysis. Management of anesthesia in hypercalcemia. For emergency surgery, we have to restore the intravascular volume prior to induction and increase urinary excretion of calcium with loop diuretics. But we should not give thiazide diuretics. Ideally, surgery should be postponed with until calcium levels are normalized. CVP monitoring and pulmonary artery catheter monitoring may be advisable in patients requiring fluid resuscitation and diuresis. Dosing and depolarizing muscle relaxers must be guided by NMJ monitoring. Sir. Thank you, sir. That's all.
Finish?
Yes, sir.
Okay. So you are mainly concentrating on hyper and hypocalcemic state. Isn't it? Your
Yes,
answer is based only on this two abnormal values of calcium, either
Yes, sir.
or high calcium. But more than that,
Nothing to
have other functions and other involvement with anesthesia. I'll just show you how this presentation can be a little different from the